Righto. I'm pretty sure you can see my slides. So if anything goes wrong, we're going to tape this and you'll get the replay. So yeah, just giving you an update on Doug's and my research. It's early access online, so you can get a copy of it. I've put the links in the chat. So yeah, let's go. So we published 2 papers. So back in 2021, I contacted Doug and I was just frustrated with the fact that academics were talking about blisters and using the term friction in the wrong way. Anyway, so we wrote this massive paper. It was way too long. Cut it in 2. The second one's still too long. So we were thrilled that the Journal of Athletic Training was still happy enough to see fit to include it, considering its usefulness. So the first paper really was all about causation, and too many people think that blisters are caused by friction or rubbing. Blisters are actually caused by repetitive shear deformation, and that is essentially the give in the soft tissue between skin and bone, and it's because of the skin and bone moving out of sync. And Doug Ritchie coined that term back in 2010, which made no sense to me at that time, but not long after that, it certainly made sense, and everything just kind of opened up from there. So the bones move, the skin stays still thanks to the force of friction, and everything in between stretches and distorts. So repetitive shear deformation is what actually causes blisters. It's not a superficial to deep wear injury. It's actually an intraepidermal mechanical fatigue within the epidermis, specifically the stratum spinosum, and it's caused by repetitive shear deformation. Shear deformation is the give in the soft tissues. So if you put the tip of your right index finger on that back of your left hand and you keep it stuck to that same bit of skin and you wobble it back and forth, that's what shear deformation feels like and looks like. It's driven by bone movement. So it's quite normal and necessary for the bones to move within our feet, and that is the driver of shear deformation and it's in the presence of high friction force at the skin surface. So the bones move, the skin surface doesn't, everything in between stretches and distorts, and when repetitive, that causes a mechanical fatigue in the stratum spinosum, and it can take up to 2 hours to fill with fluid and look like a blister. Now, shear deformation is normal, and it happens with every step that we take because our feet approach the ground at an angle and leave the ground at an angle. And it's the foot is designed to handle a lot of it, which was handy. And high in-shoe friction is normal. So we need that high friction level to keep the skin surface stationary, because we need traction for our foot in our shoe. And the structural design features, I guess, of our skin that make it resistant to shear deformation and built for high friction force is the epidermis, for example, is hairless, it's ridged, and it has a high degree of eccrine sweat glands. So all these things set it up for a high friction level between the skin and whatever it's interfacing with, ordinarily a sock. And also the plantar dermis has a higher collagen content compared to the dorsum of the foot, and we need that to store, transmit and dissipate elastic energy during mechanical deformation so that it's less likely to fatigue. So our foot is set up for high friction. It's normal for the bones to move back and forth within our foot. It's normal for the skin surface to stay stationary in contact with the sock, which is in contact with the shoe, and then the shoe with the floor. That is how effective locomotion occurs. So the 3 fundamental elements of blister formation: bone movement, high friction force, and the repetitive nature of the activity. So when we're looking to prevent blisters, we can do things like reduce the repetition of the activity, which for a runner or a walker just means not going as far, which is not that useful. We can reduce the high friction force. So if we get a low friction force at that skin surface, it just allows the skin to slide in sync with the bone at an earlier moment, and therefore there's less shear distortion within those soft tissues. So that's what a low friction force is hoping to achieve. It's actually hoping for the skin to move in sync with the bone. And of course, we can affect changes in bone motion. And if you minimize any three of these elements, that's how we approach blister prevention, basically. And moving on to the second paper, it was all about, if I could summarize it in one picture, it would be this one. It's a chart that shows the mechanisms of blister prevention. So we came up with this table or this chart to show all the ways that we can prevent blisters. So on the top left, it's reduce the repetitions, which is not so helpful. On the top right, we've got increase the skin's resilience to shear. So that is all the aspects that happen when we are training. We generally are training our cardiovascular and our musculoskeletal systems to be able to do the marathon or walk the whatever hike we're going on, and inadvertently we are training our skin too. So we are allowing positive adaptations to happen within the skin by subjecting the skin and the soft tissues to the forces that threaten to damage it, which is the repetitive shear load. And most preventions actually work at reducing the magnitude of the shear distortions. And these are all the ways that we can do that. And I don't have a lot of time to give to this right now, but this is the crux of Blister Prevention University. It's a course that we have, and it goes through all of the preventions, shows you how they work, how they don't work, and their pros and cons, and all of the research behind them. So there are tons, and I guess in the Q&A we're going to get to some of these. So I might actually leave that for the Q&A. So we look at how all the preventions work. We looked at all the common preventions in use with our patients these days and what we use, and even ones that aren't quite so popular, and we looked at how they work. And we also looked at the evidence base for all of the preventions as it stands at the moment. So at this point in time, we have evidence for adaptation, which is the training. So we impart the forces to the skin that threaten to damage it, which is the repetitive shear load. And this is things like incrementally increasing the distance that we're walking or running, incrementally increasing the time that we're wearing the shoes, and incrementally increasing the exertion component and the duration, and getting our feet used to all the forces that it's going to be subjected to. Over time, this creates positive adaptations in the skin such that it makes it tougher, basically. We have evidence for neoprene insoles. That's basically Spenco. This research was done back in the late 1960s, and it was at the beginning of when Spenco was first being developed, and they found that blisters were much less likely with these insoles than without. And Doug Ritchie's research with Kirk Herring in the early 1990s showed that dense padded acrylic socks definitely reduced blister incidence. And what they did with this research was there were two studies. The first one was a 100% acrylic sock and 100% cotton sock, and they were thick, they were padded, and they had identical construction. And so they gave them to a group of runners and they measured blisters, and they found that the cotton sock had something like twice as many, and the blisters were 3 times the size, or vice versa. 3 times as many and twice the size. I can't quite remember. So the acrylic socks outperformed the cotton socks in terms of blister prevention. Then they repeated that study, and they used, again, 100% acrylic, 100% cotton, but this time, and they were identical constructions, but this time, instead of being thick, they were thin socks. And they found that there was no difference between the two socks in regards to blister incidence. So it was the thickness plus the acrylic that made the difference. Unfortunately, I don't know of, thick acrylic, 100% acrylic socks that are available these days. It really would be good to know what's available, or, what the evidence is for socks that are in popular use today, merino wool especially. There's evidence against powders. Powders either make it worse or don't work, and antiperspirants, they don't work as far as the evidence is concerned at this point in time. The research done for antiperspirants was on military populations, and they had some antiperspirants and they definitely reduce blister incidence, but they can currently cause a high proportion of irritant dermatitis, so much so that it just rendered the antiperspirant useless because it was causing too much skin damage for the dermatitis side of things. So what they did was they put an emollient compound in the antiperspirant, and it was good because it reduced the irritant dermatitis, but also the blister prevention effect was lost. So as it stands, there's no evidence for any antiperspirants. We've got conflicting evidence for paper tape. One study said it worked, and another said it didn't work. They were based on very similar populations, the same ultramarathon races, and the main lead author at least. And with double socks, there's been 3 studies, and there's nothing we can hang our hat on there. You know, they used a lot of different types of socks and constructions and materials. So, yeah, there's a lot of variability. So we can't really quite say yet. And we have no evidence or insufficient evidence for things that you and I would just take for granted, things like footwear fit. We don't actually know whether perfectly fitting shoes prevents blisters, but, you know, intuitively, at least a poorly fitting shoe can contribute to blisters, I'm sure. Lubricants we have nothing for, which is really quite surprising. Lubricants really make things slippery, so intuitively they could have good effect. They have their downsides, but really every strategy has its downsides, its pros and its cons. We don't know anything about other tapes other than the paper tape. We don't know about toe socks. They're used quite regularly in the running and hiking populations. We don't know anything about other socks, which would be good to know. PTFE patches, we've got good, that's the Engo patches. There's really good laboratory studies on those, on coefficient of friction data, but nothing in the real world in regard to blister incidents. So it really would be good to have some research on those. Gel toe protectors, I mean, I rely on gel toe protectors a lot for my patients and customers who are blister prone, so, but nothing in the evidence, nothing for toe drops. I do them a lot in ultramarathon. And the biomechanical interventions, we have nothing whatsoever, even though we know bone movement is the driver of shear deformation. So there's so much to be done in regard to research and getting an evidence base for the things that we do with blister prevention. Again, we cover all this in more detail in Blister Prevention University. So if you just join, I'm afraid I've only got half an hour for today, and I've got some great questions. I'm really grateful for your questions. So please do keep them coming when you register for office hours. So we'll quickly race through them now. Grace and Helen asked variations on a theme, which was when to open or lance a blister and when not to, including if you have an autoimmune disorder. There's no real right and wrong answer, but there's things that will help you make a decision. So if you have someone who is immunocompromised or they have a susceptibility to infection, this obviously would be a consideration not to lance a blister, but it doesn't mean that you can't lance a blister. Like if this person if the blister is on the bottom of the foot, they need to go back to work after this consult with you. There's a pretty good chance that it's going to lance of its own accord. And if you feel like you can't take away the blister causing forces well enough, you might think, well, I better just lance this in a controlled environment, keep it clean, educate the patient on how to look after this blister so that nothing bad comes of it. So, there's so many factors that come into play. Can they even get to their feet and see their blister and reach it so that they can implement the treatment to it that they need to do once they've left your surgery? Because, you might need to lance it, you might be happy with that, you might be set up, you can do everything well, obviously, but what's the patient's self-care ability? What gear do they have? Have they got enough of it? Do they have enough Band-Aids? Have they got any betadine at home? What shoes can they wear? So this comes into where the blister is. If they've got a blister on their little toe and they can wear thongs for the rest of the weekend, that's a good reason why you might want to leave the blister intact, because as long as it's intact, it can't get infected. Similar with the back of the heel, you can wear scuffs, and you're giving that blister a good opportunity for all the fluid to reabsorb without opening it up to infection. So yeah, all of these things come into play. A few people asked about what's the best blister prevention. It's a bit of a loaded question. I don't really like the question because there's no one single best prevention for every blister location in every situation. So I really think this question is better framed around what's the best blister prevention for X anatomical location. That's the better way to think of it. And Shane asked about posterior heel blisters in hiking boots, and I'm assuming he's asking about prevention. Well, this chart, remember, shows all the potential aspects. So if we start over on the right here, we can reduce bone movement, so calf stretches, we can implement them and get them working. We can use taping to spread the shear load. We could potentially apply some gel, Silipos gel to the shoe or the skin to absorb all that shear deformation. I found that the gel on the back of the shoe, I had a bootmaker sew it and glue it in. It unfortunately really degraded quite quickly, but while it was on, it was actually really quite nice. It really did help my posterior heel blisters back in the day. And the other thing, obviously, is we can reduce friction force. So there's two ways to reduce friction force. We can reduce the pressure. The harder you press, the bigger the shear distortions. The gentler you press, the lower the shear distortions, because your fingertip ends up sliding. Yeah, the skin ends up sliding against whatever it's interfacing with it at an earlier point in time. Therefore, the skin is moving in sync with the bone. So reducing pressure by whatever means. So this is probably a donut pad on the back of the heel. You can do that. Or you can reduce the coefficient of friction. That's make it more slippery. So Vaseline, moisture wicking socks, all socks that are moisture wicking look to affect a low coefficient of friction. They're trying to keep the skin dry, and that means more slippery. So you can kind of see that Vaseline and moisture wicking socks, they don't work it to exactly the same degree in making things slippery. So you can see that in this coefficient of friction section, there are an array of preventions, and they all work to different degrees at making things more slippery. But my go-to is Engo patches. So back in 2008, this is where my blister journey started. I was at my wit's end and I came across these Engo patches, and I was starting to study more about blisters to figure out what on earth was going wrong, because I had taped my heel, I was still getting blisters, or it was still hurting, and I couldn't figure it out. So I implemented these Engo patches, and when they just solved all my problems, I thought, what is going on with this thing? Like, how is this Engo patch working? And so that's how it kind of started. And look, I have an affiliation with Engo patches. I sell them, so I have a financial interest in them. So it's a bit awkward talking about them, but if anyone comes in here and they have recurrent posterior heel blisters, it's Engo patches all the way, because there's just nothing that does it quite so well in my experience in any sort of capacity. Ultra marathon, me who's just walking, playing hockey, that kind of thing. So Engo patches are it for me. If you're asking about what my favorite or the best prevention is for posterior heel blisters, Carly asked, should a hiker tape before the walk just in case? Yes, of course they can. But I'd like to think that if they're coming in to see you and asking about blister prevention for a hike or a walk, I'd like to think that as podiatrists, we can be a bit more purposeful in our advice. They've come to see you. We're foot experts. We really should know more definitively what's the best thing to use. And if you want to get started in managing blisters better, the easiest thing that you can do in this situation, if you have a patient in front of you, they've got something coming up that they're training for, they want to know how to prevent blisters, get them thinking about their blister history. So you don't even need to know this, they just need to tell you. So they need to just tell you everywhere they've ever had a blister, and you tell them that they should just expect to get these blisters. They're the most likely ones they're going to get, have the best prevention in place before they even get to the start line. And if you do that alone, that is like easily more than 50% of it. If you add to that any areas that are calloused, and you can plainly see what areas are calloused. Remember, calluses and blisters are caused by the same forces. Blisters are the acute result, and calluses are the the chronic manifestation. So it makes sense that if there's going to be an increase in activity and shear load to the skin, then these areas that are calloused are soon going to suffer that mechanical fatigue because we're just not giving it enough time to adapt. And then if you've got a patient with you, you want to take it even further, just have a look at their structure and function. You know that bone movement is the driver of blister causation. So look for any structural or functional predispositions and advise them on what the best preventions are for those. And the best thing to do also is at the end of your consultation, give them a blister plan. So if you join Blister Prevention University, we give you the template, the blister plan template, where you just fill in the blanks. I've got accompanying information there. It really just sets your patients up for success, in whatever activity they're doing. So yes, they can tape just in case, but let's get a bit more helpful, basically. Danielle asked, what are the latest products to treat and prevent blisters? They would probably be, the two most recent would be Pelitech blister prevention pads. And in the chat, once I can get into that again, I'm going to give you the link to these. They are a groovy little patch or pad. They stick to the shoe like an Engo patch. They work in potentially a number of ways. I've got a video and that blog post explains it really well. So I might let you guys just have a look at that in your own time. The other one is Armorskin toe socks. So Armorskin socks are relatively new. And then they've got this toe sock component where you get to put each toe in his own little sock. And I've linked to a YouTube video that you can watch about those as well. Armorskin socks are really weird. They're a sock that has the inner layer is silicone. So the inside layer of the sock is silicone, so much so that you can't pull it on. You've got to roll this sock onto your foot. And but they're artificially increasing the coefficient of friction at the skin sock interface because it's really sticky there. Sounds like the wrong thing to do. However, then the outside of the sock is relatively slippery and you put just a normal sock over the Armorskin sock. So it's a double sock mechanism. And the aim is that there's slippage at the sock-sock interface, and that allows the skin surface to move more in sync with the bone at an earlier point in time. It's not happening at the skin-sock interface, it's happening at the next interface down, which is the sock-sock interface. So I'll link that out to you guys in the chat in a minute. Anton asked, what role do compressive forces play in blister formation versus shearing forces? Well, it's all about shearing forces, okay, and pressure or compressive forces play into shearing forces. And we can see it in the bottom part here. So friction force equals the coefficient of friction times normal force or pressure. So if you reduce pressure, you're reducing friction force. If you reduce the coefficient of friction, you're reducing friction force. So you can do both or both of these together, or you can do them one and not the other. So the easiest way to understand this is if you get you can do this finger on the back of the hand thing, but if you get the knuckle of your finger, press it against the desk, do it kind of light, wobble it back and forth, you can feel there's a bit of give, like keep the finger stuck to the desk, but wobble it back and forth, and there's a bit of wobble there, yeah? So that's shear deformation. Now, if you press really hard, you get big shear distortions. If you press barely at all, you can see that there's really little shear deformation happening in the skin on the back of your knuckle because your knuckle or your skin is sliding against the desk surface. So you can imagine this is a first met head or a metatarsal head. The harder you press, the higher the friction force, and therefore the longer it stays stuck to the desk or whatever interface we're talking about. That is a really good question. And this part of the chart is a really good one to get your head around. So friction force, which is the resistance to movement between two surfaces, is determined by the pressure or the normal force and the coefficient of friction. Great question. Arthur asked, the common causative factors of blisters. Well, it all boils down to the bone movement, high friction force, and the repetition. So the repetition is a pretty easy one to understand. And in regard to high friction force and motion of bone, that's up to you as a podiatrist to apply or to understand what's happening at a specific blister site or anatomical site. Figure out what's going on with the bone. Figure out in regards to motion, figure out what's happening with the high friction force. Can you reduce the pressure to reduce the friction force? Can you reduce the coefficient of friction to reduce the friction force? Make sense? We've got to start thinking anatomical location, not just blisters as a single entity requiring a single solution. Sock recommendations. Advice on toe socks. Well, Injinji toe socks are really the only toe socks that I'm aware of that are of any good quality. They can be great. They take a skin interface of an interdigital space and turn it into a sock interface. So we've got a double sock mechanism there. We've got 2 layers of sock. So that's a pressure management issue there or mechanism there. So yeah, toe socks can be great. They're great also if people have really sweaty feet or it's going to be really hot, because some of the sock will absorb a bit of that moisture and keep it away from the skin, thereby not allowing it to macerate so much and get weaker. So toe socks can be great, but the downsides is all those extra sock layers takes up a lot of room in the shoe. And if there's a swelling component, say for example, ultra marathon, things can get pretty tight in the shoes pretty quickly. And sometimes we just need to abandon the double sock. But yes, definitely worth a go. One thing that I will say is that your patients think that toe blisters are toe blisters. And therefore, if they get toe socks, it will sort out every toe blister. But let them know that it's just for the interdigital space that they're different for any other blister site. So top of the toe, outside of the little toe, tip of the toe, under the toenail. A toe sock and a normal sock are just exactly the same. A toe sock only does something special for the interdigital space and is only relevant if they're getting interdigital blisters. Apart from that, Arthur, sock recommendations, basically thicker is better than thin. Cotton is bad, which we already know this stuff. We don't know enough research-wise to really hang our hat on it. But merino wool as a component seems to make socks more comfortable. It definitely adds a thermal insulation component that people like, especially hikers. My take on socks is just get something that's comfortable. Even if it's a thin sock, go with the thin sock. If you don't have room for a thick sock, then that's fine. Just get a thin sock. If you've got a blister susceptible area, there are more sophisticated ways of dealing with that blister preventively than just hoping that a sock will take care of everything. That's my take on socks anyway. What are the main causes of blisters with orthotic therapy? This is a really good question, Tom. So if we think about orthotics, often we give orthotics to patients and they'll get a blister in their arch. Why is that? Well, if we go back to this chart, it kind of explains it really well. So that area of skin, which is normally non-weight bearing, has now become weight bearing and isn't used to having to deal with shear load. So we need to spend a bit of time in regard to orthotic wearing in timeframes for the skin to get used to it. So over time, the skin will get a bit more used to it, and hopefully that's enough to mean that they won't get the blister anymore. There's also a pressure component. Again, it used to be non-weight bearing. Now it's actually a bit more weight bearing. So there's a higher friction force, literally because of there being more pressure there. And it's not always a good idea to concentrate on only reducing the arch height or the contour of the orthotic, because generally you've got it there for a reason. You're looking for that arch contour to afford some sort of mechanical intervention, and timing of forces, changing the timing of forces in some way. So it's not always a matter of having to reduce the arch height or reduce the orthotic. You can also muck around with coefficient of friction. So literally the Spenco insole or the leather top cover that you've put on, it could be a higher coefficient of friction compared to what they're used to. So normally without an orthotic, they've got their sock shoe interface. So that shoe lining, that's insole cover, top cover. Now that, let's say you introduce a Spenco cover on the orthotic, now you've taken it to a sock Spenco interface, and potentially that interface might be a higher friction level compared to what used to be there before the orthotic. And a lot of people use the Engo patches just to troubleshoot these problem areas. Here we go. The last one, Tom asked about roof management, volume concern and location. We've kind of covered the volume concern and the location and a bit of the roof management in regards to, are we going to lance this blister or not? But basically this little chart or patient handout describes the 5 stages of blister management really quite well. So the middle stage there is where we've got an intact blister. The good thing about this blister is it's intact and therefore it can't get infected, and it may be a priority to leave it that way such that it can't get infected, which for some patients will actually be the best thing to do. But if you are going to lance it, well, you've got to realise that you're taking an intact blister and turning it into a torn blister and introducing the risk of infection. So, of course, you're going to treat that in a sterile fashion. You're going to educate the patient on how to look after it for the following days until that heals and is no longer an infection risk. But you've really got to make sure that they have all the right stuff. They can get there. They've got good self-care ability. And in regards to D-roof blisters, I don't think it's really ever a good idea to take an intact blister and turn it into a D-roof blister, but they do at some races, I know that much. And if it's a torn blister, I'll generally try and leave the roof on it if it's not dislodged significantly. But if it's just kind of hanging by a thread and it's all macerated, I'll often just nip it off, and now we're dealing with the D-roof blister. D-roof blister, obviously you could use an island dressing on that like you can the torn blister, but these are really set up for hydrocolloids. So by all means, whack a hydrocolloid on there. That really helps with the healing process, and let your patient know where they can get other ones. Also let them know that you leave the hydrocolloid on for days at a time, ideally, and you change it when that white gel bubble gets to the edge of the hydrocolloid, because at that point it's open and infection can get in or bacteria can get in. So yeah, if you want that little handout, it's quite a good one. You can get that in our free CPD course. Pre-CPD. Now we're actually just releasing, it's in work at the moment. It's released. You can go to pro.blister-prevention, have a look at our new site. It's for podiatrists and clinicians, and there's a free CPD course there that goes through, if you really want to know, an introduction to blister management and especially the pros and cons of taping. Have a look at that free CPD course. You also get that patient handout that you can copy and give out to your patients. Blister Prevention University, really every podiatrist should be doing this. Blisters are the most common injury in sport, not just foot injury. I'm talking injury overall. We're podiatrists, we're foot specialists. Really, we should be 100% onto blisters and really being able to help our patients. Blister Prevention Business is if you want to take it to the next level. It's got a whole bunch of clinical resources and revenue generating opportunities, so you can kind of turn blisters into its own revenue stream that at the moment you're probably not really taking advantage of. And there's a whole bunch of other things. You can sign up for office hours, you can sign up for our newsletter. Yeah, so that's basically that. Let me get out of this and get back over into questions that we might have had. Would reducing fluid buildup in feet reduce blister development? So I assume you're talking about like swelling, Shane. So like, yeah, when there's a swelling component, it increases pressure. So I don't think it's necessarily swelling fluid and blister fluid, I wouldn't make the connection there so much. I would make the connection in regard to pressure. It's going to increase pressure. Here's the links to the Pelitech blister prevention pads and the Armorskin socks. And that's to our new pro site. Go and check it out. And yeah, use of Vaseline over or under dressings on blisters. Okay, Vaseline under a dressing can't work because Vaseline is looking to create a lower friction level, a lower coefficient of friction with whatever it interfaces with. So when you've got something stuck to your foot, I mean, it's adhered, yeah? And so if you put Vaseline underneath, it's still adhered around the outside. And so it can't really reduce that. It can't reduce shear load more than the dressing is itself. In regard to putting Vaseline over a dressing, yes, you could, but you're at risk of the lubricant retarding the adhesion of the tape or the dressing that you've got on there. So sometimes that doesn't work. Sometimes the dressing or the tape just kind of works its way off. Make sense, Anton? All right, guys, I will bid you farewell. Thanks for joining and hope to see you next month. The first Wednesday of the month is office hours at 10 a.m. WA time. Thank you.